Now today we're thinking about the National Early Warning Score, or the NEWS. And this is a set of 6 physiological observations that we need to make to see if our patients are deteriorating. And we also need to take into account whether they're receiving additional oxygen or not. But before we go through this NEWS, let's just look a little bit about the background. So the NEWS, it's the National Early Warning Score. Now, in the old days, we used to do TPR charts, temperature, pulse, respiration charts, and blood pressure. But when I say we used to do them, they were done, but sometimes they weren't done. And this means if they weren't done, we missed opportunities for early detection. We need early detection of any deterioration in our patients. By definition, people in hospital are going to be unwell, and that means they have the potential to deteriorate and become seriously poorly. Conditions can evolve and become more severe, or there can be complications associated with a condition that means the patient can deteriorate. And it's always true to say that the earlier we are aware of something, the more likely there is to be a positive outcome. So because things weren't being done, conditions were being detected late. And then even if things were being done, so not done early detection, even if things were being done, sometimes they were not recognised. So there might have been a pathological parameter. Someone might have been hypotensive or hypertensive or tachycardic or bradycardic. But again, because that wasn't recognised as such, there often wasn't the timely response that we've just seen is so essential. So it's not just doing observations, it's making sense of those observations and not just doing them in a perfunctory way. It's understanding that parameters can be abnormal and therefore we need to do something about it. So the other problem was that conditions were not escalated. And now we realise that we need an appropriate, timely, competent response. So for example, if the patient has deteriorated as a result of a pneumothorax, it would be good to have a trauma surgeon. If they've deteriorated as a result of a cardiac complication, it would be good to have a cardiologist. The response needs to be competent. So the Royal College of Physicians wanted to standardise observations. And if we standardise observations, then we can communicate between hospitals and between individuals. We get a number that's nationally recognised. So they realised that what we needed was a track and trigger system. We had to track our patients with early detection, but then we had to trigger a response, and that response had to be competent. So the National Early Warning Score is a track and trigger system. That's why it's important. Now let's look at some of the parameters that are on it. As we've said, we have 6 physiological parameters. And these are respiratory rate, oxygen saturations, temperature, blood pressure. Now it's good to do the patient's systolic and diastolic blood pressure, but for the purposes of the NEWS score, it's the systolic score that counts, just the systolic score. And then it's good to take the patient's heart rate, usually detected by taking the pulse, and their level of consciousness using the AVPU, alert, responding to voice, responding to pain, or unresponsive. Now, there are lots of additional observations, of course, that are vital, but they don't constitute part of the NEWS score. And these are blood sugar, which is often on the same chart, which is good, pain score, urine output, the frequency of the observations and whether there's escalations and people to sign it here. So all these are really important. Now, in the NEWS score, what we have is thinking about respiratory rate, for example, the white is normal. So 12 to 20 is normal. So I might take the observations and the patient's respiratory rate is 14. And I might take it again and it's 18. And I might take it again and it's 15. So that's fine. They're within normal parameters. So if it's white, the patient doesn't score. They get a 0. That's good. But if it goes into a green zone, all these green zones that we see, that's the green zone for respiratory rate. That's the green zone for oxygen saturations. If it goes into a green zone, the patient gets 1 point or 1 mark on the news score. If it goes into the yellow, they get 2. That scores as 2. And if it goes into the red, that scores at 3. And of course, the higher the overall score, the more ill the patient is. So what we do is we count all these up and we end up with a score. So we'll add the respiratory score to the oxygen saturation score, to the temperature score, to the systolic blood pressure score, to the heart rate, and to the AVPU. And then we end up with a total score based on these 6 physiological parameters. So here we see that the patient is starting off fine, the respiratory rate's okay, and they're not scoring on respiration. But then we take the respirations again, respiratory rate again, and we find it's gone up to 20. Now if it's 20, if it's on the borderline, we'll count that as scoring a 2 in this case, because the patient's become tachypnea. Because we don't want tachypnea, we don't want it to be too fast. We don't want bradypnea, we don't want it to be too slow. And when someone starts to get sick, very often the first thing that happens is the respiratory rate goes up. So you might detect a developing tachypnea while all of the other parameters are normal. So at this stage, during this particular hour, we might find that the oxygen saturations are still quite acceptable. We might find that the temperature is acceptable. We might find that the blood pressure is reasonable. The blood pressure might be 120. Now, it would be over 80 perhaps, but that would be the diastolic. But as we've said, it's the systolic that's important. So that would be a non-scoring blood pressure. We might find that the heart rate is 74, which is fine. And we might find that the patient is alert. But the experienced practitioner will think, oh, respiratory rate is up a little bit. Is this patient developing a complication? Could they be developing sepsis? Because if the respiratory rate goes to 22, that's associated with a significantly worse outcome, actually, if a patient is septic. So we're going to keep a close eye on this patient. And then we go back and we find that actually they've gone well into the yellow zone now, so they're definitely scoring 2. So the respiratory rate's gone up a bit. And we might check the saturations, and they might still be okay because the patient has got a tachypneic compensation. They are breathing faster to compensate. But we might find the temperature's gone up to 38 because this patient might be becoming septic. This is what I'm starting to get worried about. At this stage, the systolic blood pressure is probably going to be absolutely fine. So that's acceptable. The heart rate might have gone up a little bit. It might have got a slight increase in heart rate at this stage. But the patient can still be alert. So what we've got here is we've got a score of 2 and 1 from that. So the patient's gone up to 3. So that's in the abnormal range. So I'm going to monitor this patient really carefully as the staff nurse. And if I'm the registered nurse in charge, any time that the score is over 1, I have to sign that to say I'm aware of that. So we're keeping a really close eye on this patient now because there's a possibility that things are going to go wrong. But then we go back half an hour later or an hour later, And we find now that the respiratory rate is indeed higher. It's in the dangerous area where we don't want it. It might even go into the very tachypneic area. And now the oxygen saturations have dropped a bit. The oxygen saturations have gone down to 90. Now, when someone's poorly, I don't particularly want an oxygen saturation rate of 90, unless, of course, the patient's got chronic obstructive pulmonary disease, but this is me, and I haven't. And we find the temperature's gone up to 38.9. So the temperature's gone up. At this stage, fortunately, the systolic blood pressure is still maintained. But the heart rate has gone up. Heart rate's gone up quite a bit. Heart rate's now a 94. But the patient's still reasonably alert. So what have we got now? We've got 2 from 2 from the respiratory rate. We're kind of on the borderline of the oxygen saturations, because remember, the oxygen saturations get worse as we go down. So I think I'm going to count that as a 2 as well. So that's 4, 5, 6. So the score's now gone up to 6. And we'll see, we would certainly escalate at this stage. So, but let's imagine we don't, and let's see what would happen. So I'm becoming septic now. And my respiratory rate is probably going to carry on going up if I'm not treated. And the thing is with sepsis, if I'm not treated at an early stage, some quite large scale studies have shown that the mortality rate goes up 7.6% for every hour that antibiotics are delayed. So for every 10 minutes, we don't recognise a patient who's in severe sepsis, their mortality rate goes up by over 1%. Early recognition is absolutely vital. But here we haven't recognised this, unfortunately, so we're now into the red zone there. Now, I did put oxygen on, actually, come to think of it. So there I put on some oxygen. So here I had no oxygen, I was on room air. And there I was on room air. But there, because the oxygen levels have started to drop, I went on 28% oxygen there. And of course, actually, if we had oxygen, we should have added 2, shouldn't we? So the score was actually even higher than we thought there. But we'll keep the oxygen on here, so that's 28%. That's a common mistake. People forget to add 2 for oxygen. Oxygen therapy increases the score by 2 because if you're taking oxygen, your saturations would have been even lower than if you weren't on oxygen. But because we're on oxygen, we're maintaining the saturations now, so that's not too bad. But the temperatures continue to increase. That's now 39, the temperature, so it's getting quite warm. Now, in the early stages of sepsis, pyrexia is the normal response. Now, it's interesting to note that there are parameters here for the hypothermic patient, and patients can be admitted, of course, with hypothermia. But the thing is, in sepsis, when the patient decompensates, that there can be a cold sepsis. Later on in the condition, typically, but there can be a cold sepsis, a hypothermic sepsis. And of course, that's really dangerous because it's the pyrexia that improves the function of the immune system. So if the patient's decompensated and they're cold, then that's a really bad prognostic indicator. Anyway, so that's carried on going up because we haven't treated this patient. And now we actually find that the blood pressure is starting to go down because the patient's developing a bit of septic shock now. So that's pretty dangerous. And the heart rate is still up. The heart rate's up at 110 now. And now the patient is not opening their eyes spontaneously when we see them. We have to say, "Hello, John, can you hear me?" And even then they're sort of opening their eyes, but they're just groaning a bit. So they're only responding to voice now. So I think you can see now we're in a really dangerous situation. We can add a score up now. We've got 3 for respiratory rate. We've got oxygen saturations. We're going to count that as a 2 because it's nearly on the lower parameter. Patient's on oxygen, so we add 2. Glad we remembered this time. The temperature's now up to 39, so we're going to count that as a 2. The blood pressure has now started to drop, so we're going to give a 1 for the hypotension. And they're also getting up into the danger zone for heart rate, so that's counted as a 2. And we're going to give them a 3 because their AVPU is low. So that's 3, 6, 9, 10, 11, 12, 13, 14, 15, 16, 17. Oh dear. They're now scoring 17. That is really dangerous. I wish I'd seen this earlier, actually. Because this means I've delayed by a few hours now, and for every hour I delayed in my detection, I've increased this poor patient's mortality rate by 8 or 9%. It's, oh dear, I wish I'd seen it at an earlier stage. But of course you will detect it at the earlier stage. As soon as there's an increase in respiratory rate, or a slight increase in any of the parameters, you're going to be really careful with your patient, put them on really regular observations, and you're going to escalate care. And here we have a plan of how we can escalate care. So, clinical response to news triggers. Now, with a low score, patients need to be on 4-hourly observations. The registered nurse in charge of the ward needs to be informed, and even if it's a 1, the registered nurse must make a decision about that. In the past, observations have often been delegated to junior members of staff, even unqualified members of staff, and they just failed to recognise this as being dangerous. But we do. So inform the registered nurse, who must assess the patient. Registered nurse to decide if increased frequency of monitoring and or escalation of clinical care is required. So really any patient with any Muse score should be on very regular observations, ideally more frequently than that, because patients can deteriorate quite quickly. Now a medium score, 5 or more, or a 3 in any one parameter. So if, for example, the respiratory rate was over 25, or the oxygen saturations was less than 91, or the temperature was less than 35, that would indicate a severe cold sepsis if that was the case. Or if the systolic blood pressure was less than 90, or if the heart rate was less than 40, or if there's an AVP or U, an altered mental state. And it's very important, altered mental state, that the more experienced nurses will recognise confusion, amnesia, poor judgment, and poor regulation of emotion as signs of altered mental status as well. But anyway, going down, here we have a score of 5 or more, or 3 in one parameter. So minimum of 1 hourly observations, preferably more than that. Registered nurse to urgently inform the medical team. We need to get the doctors involved. Urgent assessment by medical surgical acute care team. Consider contacting a critical care outreach, specialist nurses who understand these things. High score is 7 or more. So here we want continuous monitoring. The patient needs to be monitored all the time. Someone with the patient. Immediately to inform the medical team caring for the patient. But this needs to be a competent response. So specialist registrar level. This is a doctor with some experience of looking after these very poorly patients. Inform critical care outreach, who can advise on all the nursing aspects and the procedural aspects and a lot of the technical medical aspects on how to proceed. Emergency assessment by clinical team with critical care competencies. So here we need people that understand poorly patients. And we also need a practitioner with advanced airway skills, ideally, of course, an anaesthetist. And then we want to transfer to a high dependency or intensive care situation. The mortality rate for sepsis in this example we've looked at is already not particularly good, especially if there's a respiratory rate of over 22 or a systolic blood pressure of under 100 or an altered mental status or increased serum lactate. All are poor prognostic indicators. So early detection is vital. So it's necessary for us to escalate. And again, escalation, there's been many failures in the past, we need to escalate correctly. So the best way to escalate is with an SBAR, situation, background assessment and recommendation. So you pick up the phone, this is Staff Nurse Campbell on Ward 1. I'm calling about Mr. Jones. The problem I'm calling about is he's developed tachypnea, tachycardia, and he's dropped his oxygen saturations. So the person on the other phone knows exactly what's going on. Mr. Smith is in hospital because of breathing difficulties, complicating his chronic obstructive pulmonary disease, because that's the pertinent medical history. His normal condition is that he's normally stable but does cough a lot. But the condition has changed in the last hour or the last 30 minutes, and the patient is now got a national early warning score of whatever it is, 5 or whatever it is. I think that the problem is that the patient is developing sepsis. Or alternatively, I'm not sure what the problem is, but the patient is deteriorating. So it doesn't matter, if you're a nurse on the ward, you're not expected to diagnose the condition, but you are expected to recognise if the patient is deteriorating. The patient is or is not on oxygen. The relevant vital signs are, so of course you have to prepare before the phone call: blood pressure, pulse, respiratory rate, temperature, overall Muse score. That's actually got Muse on there, that's the old one. We're now on the Muse score. Any change in mental status, respiratory rate, skin colour, pulse, neurological change, pain, wound drainage, we want to report. And the recommendations is, I request you to come and see the patient. Do you need me to do anything now? Because there may be urgent care that's required. How often do you want the vital signs? But of course, if the patient's poorly, we always do them much more than we think. While the doctor's coming up to the ward, do we need any additional tests? ECG, arterial blood gases, electrocardiogram, arterial blood gases, urine electrolytes, full blood counts. And is a do not resuscitate order appropriate? And we would say to the doctor, when are you coming to the ward? If he says I'm coming soon, we say how soon, and we actually say how long it will be in minutes. We want to know how long it will be in minutes before help arrives. So we have to be quite precise, and as nurses we have to advocate for our patients to make sure they get the care promptly. But that is all predicated on us recognising the condition. So don't be like me, because I've just I detected this poor patient's condition too late. Happened to be me, so I'm quite concerned. And detect at an early stage. And the slightest change, for example, all this started off with just a slight increase in respiratory rate. We could have spotted things then. We should certainly have spotted things by here, when there was other alterations in the patient's physiology. And the fact that we spotted it too late means that this patient will have a higher mortality. Let's put that in simple language. That means because we didn't spot it, they are more likely to die of this condition.